esam pietuvojušies otram dialogam. Jums ir mazliet vieglāk tādēļ, ka jūs jau redzējāt to pirmo dialogu, bet grūtāk tādā ziņā, ka pēc tam sako pusdienas, solītās dzīves. Tāpēc aicinu uz skatuvi Nacionālā Veselības dienesta direktoru Āri Kasparānu. Lūdzu, ar aplausiem. Un Čehijas Valsts zāļu kontroles institūta direktoru Tomasu Boranu. Un saruna būs par medikamentu nozīmi veselības ekosistēmā, kā veicināt medikamentu pieejamību. Mēs jau mazliet dzirdējām sarunas sākumā. Šī saruna norisināsies angļu valodā. Ja kādam ir nepieciešams tulkojums, atgādinu paņemt ierīci. Tātad pirmā ir latviešu valoda, otrs kanāls ir angļu valoda. Welcome on the stage. And I just informed that this conversation or dialogue is going to be in English. So, the floor is yours. You have three parts. The definition, kā pārnes angliski ir, the sustainability, and maybe the results on that. So, who wants to start?
Our guest here, right?
Thank you. Thank
Yes.
you. And thank you for organizers for invitation for this very interesting format, which is also the first time for me in such format, and also first time for me as I'm just almost newly appointed as Director of State Institute for Drug Control since May this year. And also one of topics which is solving our agency is dealing with pricing and reimbursement and availability of medicines. As it was mentioned here at the beginning, also we see FPI weight report is very important, that it can show us comparison not only between other member states of EU, but also how we were performing, for example, 5 years ago and how we are performing now. And I have to say that looking into the last report, our country is performing quite well, that we moved like from 21 position in availability of drugs in 2018 to 7th position this year. But we are speaking about total availability. We have still some problems with availability to all patients, because in some cases we have some limited access. For example, there are some strict limitations, for example, that some medicines can be used only after first line, second line treatment, and so on. And also, we increased quite well in number of medicines available from the total amount of authorized products from only 36% in 2018 to now almost 62%, which is quite nice picture. And I think this is thanks to our quite flexible portfolio, how to undergo reimbursement process, pricing and reimbursement process, that we have now like 4 possible ways. First is classical permanent reimbursement. Second is process for highly innovative medicines. Third, which is quite new, it's since 2022, is the process for orphan medicines products, where we newly introduced also patient organizations, and also to include evaluation, for example, of effect on social sphere, as it was mentioned, how it impacts, for example, families or parents, that we take into account also this aspect of assessment. And the last is individual reimbursement model. It means ad hoc in case that there undergoes negotiations between medical officer of the insurance company and the healthcare provider, for example, for medicines which are not under one of those 3 schemes, but it is important to find some solution how to reimburse the patient. What will be new? We are now also trying to find a way about better process for reimbursement or health technology assessment for vaccines. And quite new problem is how to deal with oncology in case we have some selection of medicines based on molecular character of the oncology disease. But of course, those therapeutic indications are not in the summary of product characteristics for a certain product. So there are still also some challenges in our side.
Yeah,
Thank
thank you. Well, I will also start with actually referencing the opening remarks, the report that was mentioned here, and also by my colleague Tomas, the FBI report, where we see that we, of course, we still have quite a gap with the medicine that is available or reimbursed here. In Latvia, it's 20%. It's much lower than in colleagues in Czechia, so I'm looking forward also to the second part where we share our experiences more. But looking at those numbers, I would also say that we've actually come from a much worse state that we were in, and actually we are moving forward much faster than if we look to our neighboring countries in Lithuania, perhaps. So we do have also good things. So I'm not trying to really put this better as it is, but we are moving in the right direction. This is one thing that I wanted to say, and really the financing has doubled actually also in those past 7 years. So yeah, we are getting there, but still about the challenges and about maybe the basic process, how we get to the reimbursement of specific medicines. And there are two more points that I wanted to emphasize from our current situation that we are in. Mr. Āris already mentioned that we have quite a large private payments also, amounting to some 30% and maybe half 30%, and there are also some 11% of the new medicine for the report cohort available also privately. So that's 1/3 actually, if we count it together, keeping in mind that a lot of budget comes from out-of-pocket payments. So this is one thing that should, let's say, move towards the general availability, the general reimbursement, with moving the private payments to publicly administrated. And about the basic process. So the second part of the report that I wanted to touch is the amount of time that is needed for medicine to be reimbursed, and we have almost 2 years actually. Yes, if we look at the time, but what's the main like obstacle here is that we are still tied to the budgetary planning, and looking also back to the previous discussion about introducing new financing models. I would say that we shall move also to the direction that we are not so much tied to the yearly budgetary planning process. The parliamentary control is good and all, but still we need more we need more flexibility in decision making regarding the budget. So it's now tied to the yearly process. So those are the two things I wanted to also emphasize when we look at how fast and how much of the new medicines are reimbursed here in Latvia. And also from the process standpoint, we have our colleagues doing the all the heavy lifting in evaluating the effectiveness, cost effectiveness of the medicine. And then, we have basically two ways. If the financial participation is brings us a solution which is fiscally neutral, we move on and reimburse the medicine. So that's the best scenario for us. But if there is, and it's of course in most of the cases, additional funding needed, we look at one more actually thing that also stands out from the report. Do we look at more general availability or limited availability? And that's, I believe, the case in Czechia also. Would maybe want to hear more from that the large part of the medicine available is really on unlimited terms. If I understood that correctly, maybe you can then also correct me. So yeah, those are the decisions. Do we move on with the medicine? This is already available with some limitations. Do we make it generally available, or do we introduce new medicines, but also with pretty large limitations?
Mm-hmm. So you stated this definition part, but now it's part for transference. You are two countries, but you both were looking at the same research, but maybe there is something that you can share, or either experience or, I don't know, knowledge that you can help each other. I don't know, some practical things.
Yeah, maybe I have 2 points. First is we have good experience with that model for orphan medicinal products, because there is really quite strict timeline even for us, for our agency. We have 110 days to draft our first report, and after that there is only 30 days to take comments to this report. So the aim is to have within 1 year at latest the outcome of the process, which really improved access to orphan medicines. And also we can reevaluate this after 1 year, so it's quite flexible. Maybe disadvantage of this process is that sometimes the outcome of the price and reimbursement is that the marketing authorization holder is not satisfied with it, because the input to start the process can come also from healthcare societies. So we have one example when the product was not available, even the process went, but the marketing authorization holder didn't want to introduce it into our market. And second recommendation, which is very important, is to have transparent and understandable methodologies, that the applicant understand what is the decision-making process and which outcome he can expect. And also we have good experience with early contact with applicant. We can offer also non-legally binding consultation before applying for price and reimbursement. And also we quite intensively are organizing workshops for stakeholders, also for patient organizations, and also for learned societies. So I think this transparency is quite important, because our process is quite complex. There are so many players, and sometimes it's really not easy to find some consensus. And if the other side understands what we expect, it's much easier. And also what is important, that we also try proactively contact marketing authorization holders. For example, we have input from healthcare providers or healthcare professionals that this medicine is missing and what is happening. So we try to proactively contact the applicant. Where is the problem? If we can help with applying, or if there are some other hurdles to just not to finish the process, but just to start contact with us and try to find some solution. Even, for example, which of those 3 pathways could be suitable for them.
Thank you.
It's nice to hear about the the fast track. What do you call the fast track for the orphan drugs? I believe that we have the process in the our neighboring agency the same. Well, for us, it's the same actually. The list of medicines that we look at. And then decide whether we can reimburse or not. But we do have a specific budgetary line for medicines for rare diseases. So yeah, we do have somewhat distinction, but not maybe in fast tracking the reimbursement of medicines. One more point that I wanted to talk about is that I briefly touched maybe more from our experience here is let's say really the shifting away maybe from the decision based only on available financing, on the we could do that or not do that, because it's of course it's then the question of limitations and how broad can we then really finance the drugs. And this is also something that I wanted to hear from you, seeing that you have lots of limitations maybe. To share some experience, how does that work more in the Czech Republic?
Yeah, maybe I could take one specific limitation, that those processes doesn't apply for hospital settings. So it means for drugs which are given to the patients in hospitals, which are paid from the budget of the hospital. But we know that through years the budgets to hospitals doesn't increase too much, but the demand for money for new drugs increases. It's typically, for example, CAR-T therapies or advanced therapies which can be applied to patients only under a hospital setting. And also this is usually centered to some specialized centers. And in case the patient is treated in another center, we don't have a system how to allocate money from one hospital to another. So we find now deficiencies in these hospital setting medicines, because we know that especially in the field of gene therapies or advanced therapies, the demand of money will rapidly increase, because those are typical products which are given in hospitals. And here are in place direct negotiations between payers. We have quite complicated situation, as we have 8 health insurance companies. We don't have one, but so we have 8 players in the field of reimbursement of medicines. And delays which we have are usually done by the length of the administrative procedure. As more players you have, the harder negotiations are. And we try to shorten this by some other negotiations with our players. So we still have a lot to improve, especially with the length of the process. And what is also important, now we try to introduce, because till today there was blocking issue if the applicant wanted to apply for another application for reimbursement if another was ongoing. It's from a legal point of view called litispendence. and now we try to allow, if there is another indication, there can undergo parallelly to applications. So now we have to improve in this administrative part of the process.
Can I start
answering the questions?
Answering the questions,
yes,
because
sure.
there's I can see my my name there a lot, so it's
Go on.
it's really inviting. Actually, and the two of the questions is actually regarding our proposed transformation from National Health Service to an insurance fund. Insurance, as in insurance, if the insurance is introduced as the main financing model, but I briefly touched this at the start of our discussion. Actually, one of the central parts from our proposal moving to a fund is actually financial flexibility. As I said, we are, as of now, we are tied to the yearly budgetary planning process, and we are dependent on the specific decisions. When? Now, in October, still probably in November, and then we have to start the next year with some additional funding, and then really then we come in with making decisions. What do we reimburse? Talking about the medicine. So one of the main points was to move away from this yearly budgetary planning cycle if the more sustainable financial financing model is introduced. And we have a trajectory for more years, the increase of funding, then we can make those decision-making processes actually more much more regular basis than once a year, actually, for all those decisions that are dependent on the funding available. So this is one of the main parts. Also, the second one is once we introduce, we want to introduce the council, which consists of 4 political figures. Let's say the Ministry of Health, Minister of Finance, members from Parliament, and the other 4 from healthcare sector, actually, and to really involve them more into decision making. It's also decision-making regarding then the reimbursement of medicine and how we could make them more available. So those are probably the 2 main points. But of course, they are really dependent on other decisions, whether we do move to a different financing model or not. Those would be the main differences, I would say.
Yeah, I'm sorry, I can answer only questions which are in English. So there is,
sure.
How can digital health technology such as telemedicine or mobile health apps improve drug accessibility, especially in rural or underserved areas? In my point of view, we were discussing this also today morning, that it's a good tool. However, there is also risk of overusage, because here was mentioned very important is prevention. So these distant tools could be quite risky, that they may lead to avoid, for example, patient to visit the doctors for some preventive measurements, which is also very, very important. So it's necessary to find balance, not to lose totally contact with physicians. For example, now we are dealing or opening discussions, for example, even to distant delivery of medicinal products which are prescription only, which brings another step that patient can receive e-prescription by email, he can receive medicine by courier, and there is really risk with no contact with any healthcare professional. So, of course, these apps can help, but I'm in favor not to replace the role of physical contact with the physician or a pharmacist. I think it's very important, for example, to monitor some chronic diseases. We know that it's very valuable, for example, to have also glucose monitoring tools, not only for diabetes 1 patients. So there are some areas where this is very important, and also the outcome from those tools, together, for example, with real-world evidence and data which may arise from real usage of medicines, and after implementation of EHDS, this all, I think, will bring new information towards better understanding how the medicines work in the long-term perspective. Of course, there must be also implemented methodology how to use those data to reflect them in the reimbursement process.
Maybe you have comment or reference what the colleague said.
About the applications versus physical contact, I would chime in. Yeah, most probably the same thoughts here. Well, I don't know that there's lots of digital solutions that could help with really physical availability of medicine in rural areas. We already have those in Pacomat. But then again, I would most probably say not the digital solutions, but more involving different personnel. And there was also the Minister of Health talked about it in a bit different light, but really more involving different personnel and pharmacies, and that's why we are introducing as part of the pricing reform also the payment for pharmacists' consultations. So it's a bigger amount in more rural areas. I would say that this could most probably be a better way.
You have lots of questions.
Yeah. And
maybe I can ask for QR code, so if someone maybe wants to ask more questions, we can see.
Last ones are mainly in English, so we can both read those, but really it's a split between the ones that were in Latvian with my name on them. About evaluating more the impacts on hospitalizations, or I would say generally different areas of care, and not only care, that we look more at the medicine, the innovative medicine, really bringing down the costs in the different areas. Yes and no, we are trying to do that, but really we are in a position with, at least the public funding, where also, the hospital budget is, it's low. The basis is low. So this is really a hard question to maybe move some funds from one area to other if the first area is also underfinanced. But tying in with the previous question about the insurance fund and maybe changing the financing model, one of the also things that there's been lots of discussions to maybe introduce payment for sick leaves also in the insurance fund, as it is in Estonia. Well, looking at that, we've actually had some examples where specific medicines were introduced, were reimbursed, actually, with the premise of bringing down the sick leaves payments. Actually, well, maybe this is one of the ways.
Thank you. I will translate one question for you. There is a question: how long do you have to wait for an innovative drug that is cost-effective and registered on the compensable green list for patients with rare diseases in Czech Republic? So how long do they have to wait?
As I mentioned, it should fit into 1 year time.
110 days, I heard.
Yeah, it's like the first step. Second step is 30 days. Commenting plus 15 days plus some months also. So, yeah, generally 1 year, till 1 year.
All right. Maybe you have something to respond to that. Is it a good term or should be shorter? How is it in Latvia?
Well, it boils down to, well, if we talk about reimbursement, it boils down to available funding on the yearly basis, actually. So, yeah.
So there's more questions for you.
Yeah, there is. We have horizon scanning process in Czechia, where it's helping to plan the financing demand. We don't have like some robust horizon scanning process. We have advantage of our agency our agency has both marketing authorizations and also pricing reimbursement and HTA. So we are also aware of what will be coming in next years, and also it's very important for upcoming HTA regulation, where there will be selected primarily drugs from oncology and advanced therapy medicinal product. So we can already know now what of those products are ongoing, and problem is that there is also one question: how do I ensure that there is enough budget? Those financial questions are more or less on a political decision, which is separated from my agency. So sometimes it's hard to influence the thinking about the budget from the real demand, which also corresponds to that gap which I mentioned about not sufficient budget of hospitals to pay those hospital settings medicinal products.
And this is well, this brings well, our let's say different perspectives in here, yeah, from well, the area of expertise that your agency is doing, and actually, well, maybe my standpoint here more from financing side, yeah.
So question, can you give some examples of how real-world evidence has been used to improve the reimbursement in your countries? I think this is very important, especially for those orphan drugs. In the past, we have also some mandatory registries, but now we don't have such mandatory requirement because the applicant can also supply the data in other way. Now we are trying to introduce also collecting data from using those individual reimbursement process. We have discussions with our Ministry of Health and with our Institute for Informations in Healthcare, how to collect them. There is still problem that still those data can be understood only as additional. Yeah, the main decision is based still on clinical trials, and but I think after EHDS, where more structured data and more compact data will be available, I think there will also change the impact of those data to reimbursement processes, because now there is problem that the data are not standardized even within one member state and also within the Europe. So there will be necessary some catalog of structure for certain diseases, how the data should look like, and after that it can help more for reimbursement processes.
can agree on standardization. I hope that the European Health Data Space project would help us with that. Lots of also challenges here in Latvia. The different question about the public funding sustainability become today more important than ever before. Could you please elaborate your thought on policy changes to make it more predictable? In one area is pharmaceuticals spendings and multi-year contracting. This also includes what I was talking about, how we see it should actually also evolve our financing models in healthcare and the role of National Health Service or Insurance Fund with the sustainability of financing really at the core, to be able to really introduce a we have multi-year contracting, but really we have discussions then on a yearly basis about the differences in real world needs of the medicine actually. So yeah, this is in mind the sustainability of public financing in really what are the solutions proposals from our side, from Ministry of Health regarding the financing models of public expenditure.
Yeah, and to this question, from my point of view, I think it will be necessary to include into policy changes risk sharing with marketing authorization holders, and also maybe some models for delayed payment after, for example, some effects will show of the drug. And also what I see very important for budgetary reasons to improve control of health insurance companies, because we know that, for example, in some product you have written, in case it's not it doesn't work after 6 months, that the physician should stop using it. But we know, for example, that such drugs are used 2 years, 3 years without any effect. And maybe the health insurance company doesn't have enough control mechanisms how to find it. And there is also a way where a lot of money can be lost, which could be used in better ways. So this is not only in new drugs, but it's important also to control using of all the drugs. Because here we can lose also money if they are not used wisely.
Yeah, that's a great point. That's actually from my perspective, really a pretty big challenge. Not only this, but also using something to really. To keep the patient satisfied, but about the control mechanisms, it's also getting back to the data, to monitoring of data actually, and what's available for us. So yeah, this is tied to the collection of data. We are working on it.
So maybe I have one example of also how is connected the area of marketing authorization. I would like to mention, because it was long years my area, and reimbursement. For example, we were dealing the problem whether to authorize metformin for the indication pre-diabetes treatment. I know that in some countries it is, in some countries not, but we know that such decision will lead to big impacts also on budget, because you can have so many patients with diagnosed pre-diabetes. And so in that case, it's necessary to be really, to have really evidence-based also for marketing authorization, but also later for pricing and reimbursement. So even for marketing authorization, we found that the data were not so convincing. So this is also one example how also the marketing authorization can impact in the future the reimbursement process. And also there are some discrepancy between, for example, EMA marketing authorization, especially for conditional marketing authorization, where the data are not enough for reimbursement process. So there was also another question about some joint consultation between EMA and HTA bodies, which I think will be more important now after HTA regulation implementation, where will be better scheme for such early discussions between EMA and HTA bodies.
So last question, maybe. Yes, you can choose.
Yeah, it's about, I believe that the one that is not answered is about the process in Czechia, but one of the previous questions was about the early consultations. Could it help us more? I would say, again, from my perspective, not the early consultations, but before we decide on reimbursement, that would help a lot. Actually, we have discussed this with our partners to be able to deliver the decision much faster. If we've had discussions also about the final pricing. So yeah, that would be one of the areas that we could improve, of course. Yeah. Well, but again, I'm talking about the part before reimbursement.
All right, maybe some takeaway notes, something that you, after this discussion, you would, I don't know, go away or the lunch and you have in your head something important you get out of this dialogue.
Well, if I can start on this one, moving in the report that was brought up a couple of times, moving up from the 21st position to 7th is something worth studying. So I believe that we will look further into what did you do, something good actually, as it looks so from the report. So yeah, thanks to also organizers for bringing us together, and we'll share contacts. So yeah.
Yeah. Also, I thank you for this opportunity. I think we can share some model experience, for example, with a drug which had problems in Latvia and which went well in our country. And also, I take from here that maybe we should improve the horizon scanning and the communication into our politicians that they have strong arguments why it's needed to increase the budget, for example, for those hospitals. So this is just, as I still see the question, so it really makes me thinking about it, how to improve this, and also how to make also our process more friendly. And also I have one remark that not only the reimbursement process delays the accessibility of patients to medicines, but we are quite behind. It was also mentioned in the beginning that United States now are better in for example, gene therapies. And here, I think for the future, it will be also necessary to have more harmonized environment in Europe, not, for example, even for clinical trials, but also for harmonizing competent authorities for GMOs and competent authorities for medicines, because I see really severe delays in access of patients to gene therapies.
Thank you so much. Aplaudēsim.